Good morning, everyone. If you are here for the Community Building through Health Equity Framework online training, then you are in the right place. My name is Gina Rodriguez. I am the project manager for the Community Health Training Institute, and I'd like to welcome you to our online training today. We're so excited that you could join us this morning. So we will be presenting this training, and our trainer will introduce himself in just a minute. But before we do that, I want to give you some more information about how this webinar is going to work. So we are going to be asking you questions and looking for your engagement throughout this training, and we want you to take a look at the question box on the right-hand side of your screen, because that's where you're going to type in all of your answers. And if you're having any technical difficulties, if for some reason you cannot hear us or you have a lag in your screen, please feel free to type in and we can help you sort of through some of those technical issues. We want to let you know that we will also be live tweeting throughout this training, so please follow us on Twitter, HRIA Institute, excuse me. This is what the question box looks like on the right-hand side of your screen. Again, we want to thank you for joining us today, and this webinar is able to be brought to you for free because of the generous funding that we have from the Department of Public Health. So I'm going to go ahead and hand it over to our trainer.
Good morning. Hi, this is Mo Barboza. I have the privilege of serving as the Director of Community Engagement here at Health Resources in Action, HRIA. I'm really glad to see so many folks have joined us for the webinar, and I know some folks are still arriving, which is great. I see we have folks from throughout the state of Massachusetts and many other states from around the country, and I know we're going to be joined by a few of our friends from Canada, so happy to have all of you be a part of this learning process. Want to just go over our learning objectives. So I know you can see these, but I like reading them out loud so that we all are taking them in. Participants completing this webinar will be able to describe health equity and diversity in a community context, describe aspects of culturally competent approach to community work, and identify strategies for collaborative work when working across differences. And we're really going to be focusing in on the health equity perspective and really thinking about how it impacts community building. Great. So what we'll do today, we will define health equity. We're going to name and really discuss 4 key questions, which is a tool to help any community or organization that's looking at a disparity in their community and trying to assess the issues of equity that go with it. It's kind of an opening diagnostic to a broader process to address health equity. And we'll do all of this through examples, and we'll discuss some practical steps to improving equity in terms of policy change, systems change, and leadership development. I'm glad that folks are still joining us, and happy to have folks continue on. So a few words on language. So many of you are in the field of public health, and some of you have been working in community, and for a long time that's meant having some interaction with the public health sphere. So some of this language exists both in community work as well as in public health. And I just want to mention that over time, we have used and been really aligned with some of this language as a field. And so for a while there, we were focused on social justice. And not that we aren't anymore, but that was kind of the leading edge of practice. And then we talked about environmental strategies, which are really moving away from just focusing on the individual, but what are the things happening around the individual that impacts their risks and their exposure to disease. Disparities was a way of really drilling down to see where was it that there were differences in health outcomes. And this really helped us to identify who was suffering the most. And this is an important piece because we're going to be diving deep into communities and thinking a little bit about how do you find some of the folks who are suffering the most. Social determinants of health were the kind of big whys, like what was happening in communities that pushed and were influencing the disparities that we were seeing. And we're now landing on health equity, and I want to make sure that I say this out loud. Health equity does not replace working on disparities, and it's not the same thing. Really important that we're not just overlapping language and putting a new title on old work. It is new and different work, and we're going to be focusing on kind of defining that today. To get there, I want to share a slide with you about low birth weight in a neighborhood or a set of neighborhoods and communities just south of where I am right now. Some of you might even actually be from Brockton or the surrounding towns and on the South Shore in Massachusetts, so you'll see some of this. I bring this one up just to look at race and ethnicity disparities right from the beginning, because one of the tenets of health equity is that we are surfacing and we are willing to see what the information is telling us and what the data is telling us. And one of those challenges is that we need to disaggregate data by race to really be able to see whether or not folks are experiencing health outcomes differently, and then ask the questions of why, and then really thinking about what are the social forces that are pushing that difference. And so what you see here, for example, is that green bar is the city of Brockton, and then the other towns around it that happen to fall within the community, the Chana in that area, and then the state total. And we're looking at low birth weight by race and ethnicity, and one of the things that you'll notice is right away that there are some differences for communities by race, and that that where people are, so whether they're in the city of Brockton or the towns around it, has a significant influence on the differences in the rates. And one of the themes that we're going to be looking at throughout the course today is having some of that local knowledge and being willing to ask the question. So, for example, here we see that Black non-Hispanic folks have a higher incidence of low birth weight in the towns around the city of Brockton than within the city of Brockton, whereas our Hispanic population has the opposite thing happening. And that's something that you have to, really be on the ground and really asking the question why. Well, what's happening in that sphere? Who are the different populations within the Black non-Hispanic population and the Hispanic population? Is there a difference between the folks in the city of Brockton and the communities surrounding it? And is there a difference in care? And then obviously what are the other forces that are acting on those populations? This kind of depth is what we're talking about in health equity. So we have to develop this health equity lens, and that first piece is, are we willing to see it? And this really means that we have to build some willingness to take on the tough challenges and have the hard conversations. Are we willing to, and do we have the resources to disaggregate the data? We have to be able to break it down by race, as race is the qualifier that has, in the past, in our historical past, really been the divide around health and outcomes and access to resources and the interventions that we've tried to make happen. And so if we can disaggregate by race and other factors, we get a better sense of the health of that community and what's going on there. And then we have to have an analysis on race, power, and poverty, and we'll be talking about this as we go forward. Part of this is being willing to have the conversation, to engage with our community partners, with our coalition members, with our municipal partners around these issues. And if you can't bring up race in your community or your conversations, then you really can't talk about health equity. Here's an example of equity that is stark. This is household median wealth in Boston. We see that white households have a median wealth of $247,500. The Caribbean Black household wealth is $12,000. The Puerto Rican is $3,000, and U.S. Black $8. Now, the first time I saw this from our friends at the Federal Reserve Bank of Boston in a report entitled "The Color of Wealth in Boston," it was really jarring to see these numbers. Although if I walked around and kind of understood the community, this was not, really untrue. The largest difference here is in whether or not these households own property and own a home, remembering that household wealth is the sum total of all their assets and their liabilities. And so if you're not a homeowner and you don't own vehicles or other property or stocks and so forth, it's really hard to have any kind of high wealth. And that's the largest difference between the communities that are compared in this particular chart. It also speaks to access to resources, and one of the pieces that we're wanting to make sure we address is that when you see these things, that this is telling about today, but also really telling about the past and really investigating the historic forces that have created what we're seeing in front of us today. So I want to show you a picture that you've seen before. One of the examples that has really been emblazoned in our national kind of thinking is what we saw in terms of disparities when New Orleans and surrounding areas were hit by Hurricane Katrina. Who survived, who was impacted, largely was determined by things that were present in conditions in those areas long before the storm showed up. And so we are going to, I'm going to ask you to consider some of those things and answer a quick quiz. Which policy most aggravated the disparity between the circumstances of black and white New Orleans? Is it A, Plessy versus Ferguson, the so-called separate but equal? Is it B, post-World War II housing policies? Or is it C, levy placement and land constraints? And so I'm going to ask you to take our poll, make your answers known. We'll give you about a minute or so for folks to answer the poll. So we've got a few folks who still haven't answered the poll. Keep going, keep going. And just for full disclosure, like, I can see whether you've answered the poll or not. So, and I'm not going to call out your name, but I do know some of you personally. All right, wonderful. We see that about 20% of y'all said A, about 37% said B, and 43% said C. So all of these factors were really deeply important, and they certainly contributed to the circumstances of black and white New Orleans. But the factor that contributed the most to the unequal circumstances long before the storm was B, the post-World War II housing policies. Folks who maybe are students of this or maybe have read some of the new books around this have seen where those policies from our housing folks at the federal level resegregated and in certain circumstances segregated for the first time certain communities, made housing available to white families and not available to black families, and probably most perniciously made insurance not available to many of the black families. And so many of the places that were hit hardest by the storm were where black families had been concentrated in places that were more low-lying, more susceptible, and poverty was also concentrated in those spaces. And for a long time, many of the folks who had adequate resources to move out of those spaces could not move into the communities that were higher lying or around New Orleans. So this is the one that certainly had the most impact, but obviously all the other two did. Thank you all so much for jumping in on that poll and for being engaged. We did have a quick question from one of our participants before the poll.
Yeah, and so that question was, not that it was much more, but back into the household wealth slide that you had up. Why do Caribbean blacks have higher household wealth? They were just curious.
All right. So one of the factors that came up there was that they held fewer liabilities and over time, and that's simply a function of those families being here for less time than the U.S. black families, the African American families. Thank you for that question, and that's also a good example. If you have questions along the way, please feel free to type them in. We'll do our best to answer them either during the webinar or directly after. All right. So let's move on. So we've had another storm that hit our area. Hurricane Maria was the third of three storms that we experienced last year, and we saw a difference in how our government responded to those storms. And these aren't personal differences, these are policy differences. These are how the function of government participated or didn't participate in deploying aid and supporting those communities. And so this first chart just shows you Hurricane Harvey, Hurricane Irma, and Hurricane Maria. And we know that these struck three different places. We're talking about Houston and Florida, and then Puerto Rico. So this is the differences in federal aid on the ground in terms of those storms. If we go to the next slide, we're going to look at what that resource aid was. So this is meals and liters of water. You'll notice that Hurricane Maria got quite a bit of water and meals, but one of the significant differences is that during Hurricane Harvey and Hurricane Irma, the resources were either already in place and available on the day of, or arrived and were available one day after. Whereas for Hurricane Maria, these were significantly later, up to 7 days or more after the storm. There's been other criticisms about, logistics and getting to places, but this is an unequal response. And again, we're talking about the response of government, which is always about policy and structure. And the impact that that has on the broader community is really important. And so this is one that I want to just touch on, is monetary donations. So what did other folks give to these storms in the wake of what the federal government did? And so here you see a huge difference in what was given in terms of monetary donations to each of these storms. And these things follow from how we as a society see and act on what happened in those three different places. This is going to be, again, something we'll be studying for a long time to see what the impacts of how we act at the policy level impacts the actions of individuals. So just want to spend a little more time on health disparity. We talked about this as a difference in incidence and prevalence of health conditions and health status between groups based on many factors, but the ones that we really focus on: race and ethnicity, socioeconomic status, sexual orientation, gender, disability status, geographic location, and some combination of these. If you recall, when we talked about the low birth weight, it was race and geographic location. Important that we use examples that capture multiple factors, and so that we're getting a clearer picture of what's actually happening in those spaces. We talked a little bit already about health disparities versus health equity. I want to touch on this false dichotomy. These are not two opposite things, and they're not the same thing either. And so you can be working to alleviate health disparities separately and differently as you work on creating health equity. And I put it in those terms because it's important for us not to feel like we have to choose between alleviating suffering and addressing the conditions that create the inequities that we see. It's not a new label, all right? It's not something that you just put on what you've been doing before, and that these are both really important fronts. We've got to be working in both of these spaces. And if you're a professional that's working in health equity around a certain topic, you may want to find out who the folks that are addressing that disparity on the ground. They often have the ability to be in touch with the people who are affected by that equity. And as we're going to see going forward, we need the voices of the people who are suffering the inequities themselves to be part of the solution making. So a definition from our friends at Policy Link up top: health equity is achieving the highest level of health for all people. And from the Healthy People 2020 study from the CDC, health equity entails focused societal efforts to address avoidable inequalities by equalizing the conditions for health for all groups, especially for those who have experienced socioeconomic disadvantage or historical injustices. And so I want to just bring up that this definition from Healthy People 2020 really captures some of the things that we need to be able to parse out. A, that these are avoidable inequalities. These are not things that exist because of the human condition. These are things that choices have been made, policies have been put into place, and things have been done either purposely or unconsciously, but usually some mix of both, to create the inequities that we're seeing. And these inequalities are avoidable. They don't have to exist, which is, again, a mandate for us to do something about them. It is about equalizing the conditions for health for all groups, that everyone should be able to reach the highest level of health, and that we should really be thinking about those who have experienced socioeconomic disadvantage and historical injustices. And so we've actually done really well at looking at socioeconomic factors and low SES, for example, but we haven't always looked at the historical injustices in the same way. And that's one of the reasons why it's important to ask some really hard questions and have some of those hard conversations. Another way of thinking about equity is that it means just and fair inclusion, that an equitable society is one in which all can participate and prosper, and that the goals of that equity must be to create conditions that allow all to reach their full potential. Equity creates a path from hope to change. Part of what we're seeing here is also that our ability to create equity must also be a call to include all people and really think about how they all reach their full potential. And even though we start with and very often focus on differences because of historical injustice around race, we really are thinking more broadly into all those categories that we saw there, so that we're, again, reaching all people with their opportunity to reach their full potential. So I'm going to show you one of my favorite charts. I know some of you have gone apple picking before, and some of you have been very close to the apple, and some of you have been a little further from the apple. This chart really is about the differences between equality and equity. So on the left is the idea of equality. Everyone gets the same resource, regardless of their ability to reach the outcome. And so you see on the left that everyone has that same box, one box, equal set of resources, and your ability to reach what's up there in terms of the branch is not really taken into consideration. On the other side, we see that equity means that people get the resources that they need to all reach the same outcome. And so putting into place a distribution of resources that allows those who have historically not had resources or have not been able to reach those health outcomes to get to that same outcome that those who have in the past had them. Important that we are measuring not by the reach of those who've had the best outcomes in the past, but also by what the good health outcome is. So we don't want people to just live as long as the folks lived in the past. We really want them to live as long as they can and as healthy as they can, and address these for everyone, including those who've had resources in the past. And so it's a real focus on health outcomes. What are people actually getting to? The resources that are available and that folks need to be able to get to those outcomes, and positing, is this an addition of new resources or a redistribution of what's existing? I know many of you in public health are not holding your breath waiting for a avalanche of new resources coming into the field. What we have are broadening partnerships that bring with them different kinds of resources that can be a part of helping folks reach the outcomes that they are reaching for. And so we may be thinking about how we use different resources to help folks get to those same outcomes, and redistributing how resources have been distributed in the past. This can be a contentious process and conversation in many communities. It forces us to ask the question of how resources have been distributed in the past, who has and hasn't had those resources, and the hardest question, why? But health equity, again, is about making sure that we are asking some of those hard questions, and as we saw in the definition, really making sure that everyone has the opportunity to reach the highest level of health for all people. I'm going to talk you through an example in a community that has experienced historical injustices at the policy and kind of structural level, and what the real outcomes were for the folks on the ground. This is a picture of West Harlem, kind of in the, I want to say the like 170s, kind of high up in Manhattan. That smokestack that you see there is a sewage treatment plant that was built, I want to say in the 50s and 60s, and part of what happened in terms of even placing that sewage plant there was that this was a district that had poor representation, didn't have folks who were voting at the same level, and held little political sway. And so when the folks in the planning offices and in the economic development office, and let's make sure we don't exclude the mayor's offices there, looked around and said, where can we put this? They put it in this community where they felt they wouldn't have any retribution from the voters. What it meant in that community was that because of that smokestack and the fumes emanating from the plant, that people literally locked themselves into their homes, covered up the windows, sealed the windows, closed the doors, put a rag under the door in the crack, so that the air they were breathing was better inside because they could not stand the air outside. It also meant that there were ill effects for children, families, and the elderly who were living in those communities. And so there were really high incidents of asthma and other respiratory ailments. And as you can tell, the difference over time was that this outdoor basketball court actually began to be used. So this is a forward in time picture. But when this, for the first 20 years or so that the community was fighting against this plant, people did not spend any time outside because the air was so noxious. Part of being able to change the policies that put the plant in place and the ask to remove the plant didn't materialize. What happened was that they were able to downsize how much sewage the plant was taking in, and then how much they were processing, and also to mitigate some of the fumes by doing things to clean the air around that area as well as what was coming out of the smokestack. And so over time, folks were able to better use the outdoor space. The health equity piece here was obviously around the who had power and who didn't have power to have this happen in their community, and that the mostly Black and Latino population in West Harlem had suffered these health outcomes, not as something that choices that they had made or behaviors that they were exhibiting, but really about the environment and what they were subjected to, which was really from the policies of the city and what they put in place in terms of the plant. The other thing to add was that the plant also, over time, was processing much more sewage than what they had planned for, and so even the planning that the city had done was poor there. I want to talk about another concept in health equity that is deeply important. This idea of going upstream. Now, some of you have heard the story of people come to the river and they see a baby floating in the river, and so they wade out and they pull the baby from the river, and then like 10 minutes later, there's another child wading in the river, so they go out and grab that child also, and then 10 minutes later, there's another child. And sooner or later, folks start asking what's happening upstream that is causing these children to be tossed into the river. And this is a really good analogy for where we find ourselves. We need to save the folks that are in the river, but we also need to go upstream and really think about what are the conditions that are causing this, what we're seeing, and then be able to address it. So on the next slide, we talk about three aspects, this idea of upstream, midstream, and downstream. Downstream is really about addressing the impact of the results of the inequities. So what we're seeing in the health outcome differences in the populations that we address or where the data takes us. So for example, in our West Harlem example, there were high rates of asthma. And so folks began by diagnosing and then providing supports to the people who were exhibiting the asthma. And if you think about it, there are ongoing effects. This is, bad air in one place, poor health conditions, asthma and other respiratory impacts on children. They did poorer in school. They had less economic opportunity therefrom, and so forth and so on. And this is why it's really important for us to take a step back and understand what the forces are and what their impacts are downstream as well. So really here, if we're doing downstream work, we're talking about engaging with the affected population after things have happened. Midstream is addressing some of the conditions that create or perpetuate those inequities, and it's really about finding ways in which we might be able to mitigate what's already going on or trying to address those conditions so that we don't see as great a inequity downstream. Upstream is about really removing the conditions that create or perpetuate the inequities. Oftentimes this is where we're getting to the policy place. It may also be about social norms and some of the social constructs in certain communities, really addressing things at a level that impact the entire community. And so we'll be talking a little bit more about upstream as we go forward, but I want to make sure that we got a chance to think about this. So I'm going to give you an example, and we're going to do our second poll for the morning. Is getting a supermarket to open in a community that is a designated food desert, is that a downstream, midstream, or upstream strategy? And for those who are like, what's a food desert? That's an area in which there is not a supermarket and a way to obtain fresh foods and vegetables in a comprehensive way. So take a minute or so and try to complete the poll there. Is it A, upstream, B, midstream, or C, downstream? All right, remember that we can see if you're participating in the poll, so take a moment to complete the poll. Again, is it A, upstream, B, midstream, or C, downstream? Let's keep going. All right, so we've got about 17% said downstream, 43% said midstream, and um, looks like 40% said upstream. So we've got a little controversy there. Some folks in upstream, some folks in midstream. Really important for us to go back to the definition. So I'm going to do something that never happens in a webinar. I'm going to click back and look at previous slide. So upstream is about removing the conditions that create or perpetuate the inequity. Midstream is about addressing the conditions that are perpetuating or creating the inequity. And so the subtle difference there is one removes the problem, the other really addresses the problem. And so when we think about a supermarket, it's putting fresh foods in there without addressing why fresh foods weren't there to begin with. And so it is a midstream strategy. Thank you all for jumping in on the poll there, and hopefully that helps you to make some differences between removing the problem as opposed to just trying to address or ameliorate the problem.
We do have a clarifying question.
Okay.
You want me to read that?
Yes.
So the question is, so health equity is achieving the highest level of health and health disparities and differences in health outcomes. So if I'm involved in health disparities work, I work on identifying and quantifying health differences. If I'm involved in health equity work, I'm involved in working to equalizing conditions, providing new resources or redistributing resources to achieve the goal of high level of health for everyone.
So I don't want to wordsmith too much there, but I want to make sure that we don't see health equity as just equalizing conditions without a real focus on the highest level of health outcome. It does not help us to make the majority population sicker so that everybody's at the same level. We really have to be bringing those folks who've been suffering health equities or health inequities up to the highest possible level of health outcomes. And oftentimes that also means raising the level of the people who have had the resources. It really is about making it a healthier community for everyone. Hopefully that helps with that question. Please keep the questions coming. So we're going to use a tool that helps us to really thinking about how to address a system. So these are 4 questions. So when we see an inequity, we ask who benefits from things as they are, who is harmed by the way things are, who leads on this issue, and then who decides about the things that are at the policy level or the high level upstream that impacts the inequity that we're seeing. And so part of what we're going to be doing next is to take an example, and I'm going to be asking you all to participate in that space where you can enter information to answer these questions with us. And so the area that we're going to look at is where we started with the example before of a food desert. So I'm going to ask you who benefits from the food desert existing, from the community not having access to fresh vegetables and fruits and other fresh food, and there being other places there instead. Who benefits from that? And try not to just think about the kind of causal relationships, but there may be people who benefit from it who had nothing to do with why it happened. So again, we're asking you to type into the chat there your answers to this question. Who benefits from the food desert and conditions being what they are? And I'll give you a minute or so to add some answers in there. Keep going. Let's see if we can get a few more answers there. Okay. Let's add in a couple more. All right. Um, you can still add things, but I'm going to um, kind of sum up what we have. So local bodegas and convenience stores, so kind of the small stores that are in place. Fast food places, and lots of folks identify the fast food industry and other pieces of the fast food industry that are there. And some folks even added the folks who make the highly processed foods that go into those spaces. So it's a little bit further up the chain, but deeply important that they are retailing most of that through these corner stores and the fast food places. City and town taxes, and that's a really important one that, would your town rather have 8, 10, 12, 15 places that are paying them taxes or have a supermarket and a couple of fresh food places and have fewer places that are paying them taxes. Fuel providers, gas stations, people commented on transportation companies. Certainly all the folks who own all of this, whether they own it locally or higher up the chain. Great job, everyone, on thinking about who benefits from this. I was a little kid who went to the local bodega and bought my, Funyuns, which were fake onion rings, and certainly benefited from them being available on my way to school every day. Um, and I use benefit in quotes there. So let's move on to the second question. Who is harmed? Who is really harmed by the situation as it exists? Who is harmed by there being food deserts and the things that you talked about being present? Again, use that chat space to answer the question, who is harmed? All right, try to get one or two more answers in there. Those of you who are still contemplating. Right. So we had a lot of folks talk about families, those who children and elders, seniors, people who are infirmed, folks with less resources, so poor people, people without transportation, um, the public health and the health of the community, healthcare, also, and insurance providers. And this is a really important point that sometimes gets lost on the healthcare folks is that they actually are suffering from these conditions being exacerbated in a certain community because they then are being reimbursed at a lower level. Folks are not being able to pay, and they're showing up with worse conditions and generally not being healthy, which hurts their work as well. I really appreciated folks calling out the kind of vulnerable populations, people with vulnerable health conditions, people with disabilities, folks without cars, and obviously that there are some smaller audiences and so forth, but also that the town also hurts, so the area that you're in, it also hurts, and the environment around it, and all the kind of on effects after folks are supplanting their, or I'm sorry, they're supplementing their diet with things that are really unhealthy. As we talked about, all the things that would happen with children and others in terms of not getting the food that they need or not eating well. Things like obesity also came up. Thank you all. Y'all did really well with that one. The next question is, who leads on this issue? And I want you to think about it from both sides. Who leads on this issue? Who are the folks who are the proponents of the way things are, and who are the folks who are the folks trying to do something about it? Who leads on this issue in your communities? Chris and Doherty said grandmother. She's my new BFF. Who leads on these issues? Who might be some unusual suspects who are part of keeping things the way that they are, advocating for change? We got a lot of wonderful answers there. I'm going to try to capture these as best as we can. City and town government, obviously the kind of political as well as the surface infrastructure within your town. So could be your planning department, could be economic development, could be public health, could be any of the different kinds of offices there. All the activists, community members, grandmothers, as folks mentioned, who are part of the process, as well as some of the civic bodies within your community, whether it's your chamber of commerce or your business association, other parts of the kind of community that come together who might be able to either be proponents of change. And I also saw that folks identified who would be some of the folks who are perhaps leading in terms of keeping things the way that they are. So your convenience store lobby, or some of the folks, maybe even your business associations and so forth. Someone named Main Streets as an opportunity there that they can maybe help to make a space be available for a supermarket. They also identified lenders and some of the people who make some of the decisions about who gets to be where as a space there, so developers as well. And I also saw a real emphasis again on public health, healthcare, and insurance providers, that they can really be advocates for making the kinds of change that we need. And so the last question I'm going to ask you to consider is, who decides? So we've got these folks who lead and are putting forward what they think, and we've got activists who are trying to make the change happen. Who are the deciders that we need to impact and leverage to get change to happen? So I'll give you a chance to address that. Take a few more moments to ask folks to answer that last question. All right. Good. So we've identified quite a number of different deciders. I want to just summarize that. City and town government, especially thinking about where you live or trying to make your change, really being familiar with the levers of change are in your local government, whether it's a strong mayor or a weak mayor, if you've got a town council or alder people or however it's structured, really being aware of where the power resides to make some of the changes. Zoning board is really important. Oftentimes there is a need to make some changes in zoning that would provide the opportunity for something different. Your health board can be a really important decider in terms of what's available and in demanding that other things be available as well. Attorney General, and I think in here we embody kind of all the different pieces of kind of the legal renderings of that are important, and also really thinking about are there ways in which we can ameliorate some historical injustices, and very often that can be through the law. I saw also folks really keen to say that the people decide, that voters decide, and that community decides, and that's a really important piece to always be aware of, that there's power in community and power in the people to make the changes that they need, to pull the levers that need to be pulled. Also, folks mentioned philanthropy and charities and funders, that oftentimes they can influence some of the change, or how they fund and what they fund can influence what we're seeing. I also want to mention that my good friend Stephanie Sutherland Ramsey pointed out that the folks that are proponents of some of the forces that maybe are causing the changes to be in place, and that it's important that as we see communities that are being affected by dislocation of people who are live there now for other folks coming in, and sometimes called gentrification, that it's also important that you're bringing in fresh foods and opportunities for healthy food for everyone. One of those midstream activities in terms of bringing in a supermarket, it also matters what kind of supermarket you're bringing in. If you're in a community where people have less resources, bringing in a high-end supermarket does not actually help the people in that community. Thank you, Stephanie, for being my conscience still. I want to thank everyone for jumping in on that exercise and for really providing us with some really good information and sharing with each other some of what you see as the answers to these questions. And again, to say that this is a tool to be a part of what we're doing, to do a quick snapshot of what you're seeing in terms of disparity, and that as you identify folks in any of these four places, all of these folks are possible allies. And sometimes it takes some of the naming and putting the people up on the piece of paper, the flip chart, the dry erase board, naming it out loud so that you can think about who might be an ally who maybe you hadn't thought of yet. So, for example, in the who benefits, there may be folks in there who, this was not their purpose. This isn't what they got involved for, and that they might be able to be an ally for you, even though you may assume that they may be in a different position or have a different interest in this. So thank you all. I want to share one more example of these four questions. This is a tobacco example. And if you think about current tobacco laws and what's in place, who benefits? So tobacco companies, advertisers who are able to be paid for by those tobacco companies, lobbyists and politicians, people who receive payment from that industry, convenience stores, retailers, and wholesalers, the folks who receive money to be able to retail and supply the products, and then the smokers themselves, the people who consume the product. Who is harmed? Really important. We smokers are one of the folks who are very harmed by what's in place now. And this is a really important piece for us, is that we're never talking about the people who are making choices that they see available to them. We're always going broader than the choices of individuals and really thinking about the forces that are in play. Who is harmed also includes the smokers' families and the people around them, and groups that are targeted by the industry, including youth especially, who the tobacco industry targets very directly. Healthcare costs and the taxpayer, and the taxpayers are often paying for the health costs of people who've been harmed by tobacco products in exorbitant ways. Who leads? There are definitely advocates. There's folks in the legislature. There are lots of elected officials, certainly community members and youths and parents who are deeply engaged in trying to make change. Boards of health and the healthcare industry, and obviously our departments of public health, are all folks who are leading on this issue. And then the folks who make decisions, federal agencies are really important. We've seen lots of federal cases that have really helped with prevention around tobacco. The courts also at the local level as well as the national level. Boards of health in terms of what they're able to pass in terms of regulation, and then at the local level, legislature and other elected officials that can pass things like ordinances and laws that help to protect the public. And so this is just another example of how we answer these four questions. And as you're seeing a specific topic that you're working on, being willing to answer these questions and answer them in ways that maybe bring up some hard truths. So if you're thinking about the disparity, economic disparity in terms of jobs in your community, there may be some instances of historical discrimination that have been in place, and that may be one of the reasons why you're seeing what you're seeing. And so being able to honestly and wholly bring up things. All right, so we're going to move forward from here and talk a little bit again about these questions. The who pays and is harmed is really an important space for us to be in, because it brings up how the folks who are harmed can and should be part of the process, and should also be empowered to help in the solution making. So we're going to take a look at an example. Our friends in Multnomah, Oregon, and some of you are going to Google this afterwards and say, where is that? It's in Oregon. It's way up there. And this is Ben Duncan, their former program manager for the County Health Department Equity Initiative, and now he's doing some countywide diversity and equity work. His quote is, "When we talked about disparities, it was simply reflecting the data. We weren't telling the whole story. We weren't talking about the structural pieces. Until we started looking through a lens of race, power, and poverty, we weren't really moving upstream. Now we're focusing on the conditions that lead to the outcomes we see." This is a really important piece, that people get really focused on what's in front of them and what's directly impacting them today, and very rarely start to really thinking about the conditions and what's upstream. And this is where they saw that they were working really diligently on the disparities, and because the data showed them, where the pain was in their community, but they really weren't looking at the structural pieces that caused the pain to come into being. And so they did a bunch of work. They started with a cross-sector collaboration. They screened, some of you hopefully have seen this set of films called Unnatural Causes. They screened that all around their community with lots of different partners, over 500 people in small groups of 25 and 50, or sometimes smaller, sometimes bigger, and use it to facilitate a conversation about what people were experiencing, and really drawing up this lens on race, power, and poverty. And that the decisions that people were making around their health, and the things that impacted them were far beyond what was left to an individual, but really the driving forces in their community. And one of the things that came up for the health department was that they were a force in that community, that they could really think about acting differently in that space and really develop their equity and empowerment lens in terms of the services that they provided, the policies that they had, the practices that they used, and the procedures that they used. Really examining how the health department did its work. And one of the things that came out of this was that the health department saw that economic opportunities were one of the biggest challenges for the folks who were experiencing those health inequities. And so they decided that they would spend their dollars in a way that helped them to support the economic development of their community. One way to do that was contracting that promoted economic development within the local area and with the communities that they were experiencing those bad health outcomes. And this can be, if you're a large institution, you're purchasing lots of different services and lots of different products, and who you purchase from impacts the economies of the people in your community. They also applied for grants and built lots of new partnerships and instituted a few new positions to really be able to address the problem that they were seeing. This was one institution in a broader partnership, really thinking about, for them, what could they do to really impact the inequities that they were seeing, and taking responsibility for perpetuating some of the conditions that were creating those inequities. In this case, namely the economic disparities that they were seeing. So some practical steps to really engaging any location in terms of health equity, and really about almost any topic. First thing we got to do is gather the data. Do we have what we need to be able to see the picture? And can we disaggregate it? Can we pull it apart so that we can see how these health outcomes are being experienced by the different populations in that space? Can we be bold? Can we have the conversation that needs to be had that includes an analysis on race, power, and poverty, that says, what has been the historic forces in our community that have created what we see today, and what's the responsibility of those in our community to help make that change, and who has the power to make those changes and who has not had the power to make those changes. Examine those existing disparities. Are they in place, and for whom, and how are folks experiencing them? Look upstream. What are the policies and structures that create and perpetuate the conditions that you're seeing? And how do we remove those in place? Answer those 4 key questions that we've been doing. Who benefits? Who pays? Who leads? And who decides? And then, most importantly, be bold. Target a change that you want to make and get involved and aligned with your allies and find those points of leverage to make that change happen. Plan and act. And I always say to folks, this is not a linear process. We list these in dots on the page so that we can follow them, but realize that you've got to go back and look at the data and see, did you move the needle? Have you made the change that you thought you were making? If so, great. What more can we do? If not, what else should we be looking at? And important in this space to make sure that we are engaging and involving the people who are suffering the consequences of those inequities, the people who have the disparities and the poor health outcomes. I want to target next on who leads, because it's really important that we are building a broader group of folks that senses that they are responsible to do something about the disparities that we're seeing, and in terms of really creating and building the health equity that we want for our community. So not just the people who feel like this is wrong and we should ameliorate it, but the folks who are willing to participate looking upstream. And so this really takes a cross-sector collaboration. You really want to be thinking broadly about who can and should be involved. It takes really considering who the usual and unusual partners are. So, for example, where's your police chief in all this? How are law enforcement involved in this location and in the areas in which you're trying to cause your change to be? They often are already part of the community in ways that are structural. They may be part of your coalition. If not, maybe you want to bring them on board. Are there other unusual partners? Are there civic organizations that are in your space that haven't participated? Are there cultural organizations that maybe could bring in some of those partners that you'd like to have that don't have? And are there people who have influence on those deciders who aren't part of the conversation? Whether that's your Rotarians who absolutely exert a wonderful moral and powerful voice and force in many communities, or communities of faith who can often reach lots of different kinds of constituents because they bring together people from lots of different parts of our communities. Is it civic clubs or other kinds of organizations where people are already coming together, really thinking about where are some of those partners who might be affected by the disparity that you're seeing and or good allies for the change you need to make. And this last dot really is about including the voice and participation of the affected group of people. This is deeply important because we often miss out on having the best solutions for problems because we haven't included the people who have the most experience with the problem. And so we want to make sure that they are involved and engaged, and that you have representation not just at the presentation of data, but really in the solution making and the understanding of the problem. I like to say to folks, if you've got some disparity data, go and ask the people who are affected by that disparity directly. Ask them if they see it, ask them what their experience of it, and ask them what they think can be done about it or should be done about it. And really hear what folks have to say, because oftentimes their solutions and their take on the problem might be things that we haven't considered. So partnership can be a really powerful piece, and again, finding allies. So once you've done the 4-question analysis, allies can be in any of those spaces, and very often you'll find that you have allies who didn't think you would be able to get, or folks who didn't know about the problem and would step into a partnership if it was available to them. I want to talk about our friends in Greater Worcester. The Community Health Improvement Plan there identified an opportunity to really prepare the people who were suffering the health outcomes and the bad health outcomes and the disparities. They said that within their plan, they would specifically target eliminating institutional racism and the pathology of oppression and discrimination by promoting equitable access and to help promoting resources in the community and reducing some of the structural environmental factors that contribute to health disparities. That's a big, big goal there, and we're really happy to see it being named so clearly. But one of the things that they went further is to say, how are we going to really bring people into the process so that they feel ready to be the change makers and leaders in the community? And so what you see here is that they dedicated part of their community health improvement plan, that's what a CHIP is at the top, to really focusing on some grassroots leaders and including young people to recruit and organize these folks and to enhance and develop training programs for these grassroots leaders so that they can be better prepared to address these health disparities and to really focus on health equity. And that meant identifying folks, providing them with the resources to gain the skills and knowledge to be really engaged in conversations, and then creating spaces for that engagement. And I want to really be clear about this, is that we cannot ask people to join our collaborations if we have not made space for them to be powerfully a part of what we're doing. And so if you're in a coalition that you know you're not engaging the people who are experiencing the disparity, find ways to bring them into the conversation, not just to help the coalition really understand, but also to bring them in a way that provides them with some power in that space. I use task forces, I use co-chairing, I use advisories as ways to bring people in who maybe haven't been a part of the process in the past, but whose voice, experience, and insight is really important to what we're trying to do. And really can also be a space for you to find those folks in the community who maybe are part of the target group and also have some interest in this, in health and health outcomes, and in making change in communities. Last of these questions is the who decides, and this is can be a really challenging one for people to figure out exactly where my opportunity is. Where is it that I can really get engaged? And really, again, what we've done in those questions that you saw before was to name who makes decisions, and then part of your role is to figure out, are there any allies in that space? Are there people who maybe are low-hanging fruit, who if you provided them with some information and education, they may be able to be on your side? Who are the folks who are definitely not on your side? Who influences those folks and so can be targets for your advocacy? And then what are the processes by which power is wielded that you can help to make change? And that can be ordinances, that can be your zoning board, that can be laws being passed. What are the different ways in which people are working that can really be accessed to make things happen? And one of the ways that I've named this for folks is it's not just passing a legislation. It's also what that legislation does or what that ordinance does. So what are the contracting agreements? What are the grants that are involved? What are the regulations that go with it? There are lots of different spaces within which you might be able to affect something that actually helps you get to the decision that you're looking for. I'm going to share this real chart on voices of difference in decision making. So we want to make sure that we're recruiting people into the process, that their engagement means that their voices are powerful, that inclusion means that they have powerful roles, and that empowerment means that what they bring is access, used, and part of the process. This is how you build relationship, but it's also a product of those relationships. And one of the things that I've asked folks, especially if you're a coalition leader, is to go and be a part of the other coalitions in your community where perhaps some of these folks are engaged already. If I'm going to be asking the police to come and join my collaboration, I want to make sure that I'm at National Night Out with them. I might even join their planning committee to say, hey, what's important to you is important to us as a community, because that's certainly what I'm asking them to do with me. Finding ways to build collaboration such that the first time you're asking somebody to do something for you isn't the first time you're talking to them, and that those relationships can be nurtured by collaboration, by engaging people with what they're working on, and also by making sure that we're not alienating people who might be a part of a solution that we haven't even thought of yet. These are 4 really powerful questions, and they're really important for the process of really thinking through how health equity is impacting our community. And they're important for community work, especially if you're really working in communities that have been impacted by disparities. They are living with the examples that you're going to find in asking these questions. They've already suffered through some of these pieces. Now, it's really important that we build our cultural competency in terms of doing this work. A great piece of why this works really well is that you're engaging people and asking them to share from their experience and from their insight. And that's, a central tenet to cultural competency, is that allowing folks to be heard from their perspective. And if we do this well in community, then we're creating powerful places for all the different folks in our community. Also, that when we're working collaboratively across difference, it's important that we're building the relationship around and not just through the work. And so if you're trying to engage a community of faith, have they ever seen you before? If you're trying to engage communities of color in your town that maybe feel very isolated, how have you invited them into what you're doing more broadly before you're asking them to help you with something? So really engaging with folks in a way that allows them to engage with you, and also in a way in which you can be helpful to them. I want to stop there and ask for questions, and if there's anything that folks have that they want to bring up from today. I did see some criticism about the food desert term. There are several folks out there who have started to really question whether or not we can use that term, and also what some of the implications there are. And even some of the definitions can be really challenging. The resource sharing that I see people doing, please click on stuff that people are putting up there. It can be some really wonderful pieces. My good friend Dylan has an article that he's put up there from City Lab on equity, and it's not the food deserts, it's the inequality is the name of the article, and that can be a good resource for folks. I've actually seen that one too. Any questions from folks? Kristen points out that community readiness is important. I want to hit that question on the head because I think you're absolutely right, Kristen, that assessing the readiness of your community to be engaged in the process is important, but that assessment isn't a light switch. It's not yes or no. It's to what level, and then what do we need to do to make them more ready. I think some folks go, oh, this is going to be too hard for me to talk about at town meeting. I'm not going to bring up these issues. Folks don't want to talk about it. That's part of the reason why the inequity persists, is that it's been available to people as being invisible, and we can't perpetuate that part. Other questions? Any other things that came up for folks?
Question that says, is there a tool to assess community readiness, asset mapping, who's doing what, or in lead?
So there are community assessment tools, and what I'd say to folks is that I haven't come across a specific one that's tied to any of these inequities. What I have seen is many community assessment tools that ask you to really look at where the assets are and who's in leadership and what those pieces are, and I can probably share some of those with you, Crystal.
And the slides will be shared at the end of the webinar. I know a couple people have been asking, and we will also post a recording of this webinar on our website and our YouTube page, so be on the lookout for an email with all those resources as well.
Any other questions or thoughts before we close up? We actually have a couple things to share, so don't run off just yet. All right, I'm going to hand it off to my good friend Gina, who's going to tell you a little bit more about what's coming forward.
Yeah, so this is the first installment of our Health Equity series. So we have an in-person training that's happening on Thursday, March 15th. It will be in the Worcester area at Assumption College. So if you've already registered, we will see you in a couple of weeks in Worcester. We will also be repeating that full-day training in Boston on Saturday, April 28th. we're nailing down the location as we speak, and so we will get some more information as we get it as well. And in April, we have another online training or webinar that talks more about sort of using social media in your work. So definitely some amazing things coming up for us, and we hope that you're able to join us. But before we close out, it looks like maybe there was another question.
I want to mention that, and this is a small plug for that March 15th session. I'm a lot more interesting in person. All right? Small plug there, small plug. What was the question?
It says, I actually work with a population that suffers from addiction, and we are constantly advocating to be sure that they are at the table.
Yes, absolutely. Not only is that really important, but oftentimes people's ideas about who is addicted is framed from their assumptions about who are the folks who are using, and they're usually wrong. So deeply important that folks who are in the addiction community are part of the process, are at the table and part of creating the solutions. I'll give a really short example. I was working with our public health department in one of our communities, and when we were able to map where the overdoses were happening, it was really important to have folks from the addiction community who were able to say, this is what's happening in this space that's different than this other hot spot that's happening in this other space. It was important to have people who are working with the homeless to say, that's a space where we know we've done some work, and here's a space that we haven't done. It was important to have law enforcement be able to look at it to say, you know what, we're really aware of what we're seeing in this space, but we really don't understand why this is showing up in this other space. It was important to have public health folks and healthcare folks who could say, yes, we're receiving these folks, and these are the folks who we're not seeing. So as we understand the problem, it's really important to have lots of different perspectives who can help people really get a better sense of what's happening and then what the solutions might be.
Looks like we have some connection around the addiction work, and Kirsten shared that often barrier is inequitable allocation of city and state resources to address the overdoses.
Good stuff. That's something that I think we're all struggling with in terms of where the resources are and where they aren't. I would say to you, the building collaborations across providers and the people who care for this community is really important, and often the people who are impacted by addiction don't look like and don't come from the places that people think they do. It is a problem that's very democratic in terms that it's affecting communities with all different kinds of resources from all different backgrounds, from different racial identities, and different cultural identities, and it's important that we have all of them at the table as the impacts are different in terms of those spaces.
So I think that's it. Again, if you have any other questions, please feel free to email us. There will be a survey that will pop up once you close out this webinar. We take all of your feedback and input very seriously, and it'll help us plan for next year. So please feel free to take that survey for this specific online training. And then we also included a link for a SurveyMonkey survey that we're sending out, again, to plan for next year. And if you have any thoughts about this training or future trainings with us, please feel free to send us your information and your thoughts. Again, we will follow up with all the slides and resources shared today. And thank you so much for being a part of this, and follow us on social media for more information.